Hi guys, this is David Villar and welcome to this third video on toxicants that affect the kidneys. On this video we will discuss NSAIDs and cholecalciferol. If we start with NSAIDs, the most commonly encountered situation in small animal toxicology is the massive acute ingestion of NSAID containing medications. As we will see, the management of an acute poisoning is essentially symptomatic and supportive. The kidney damage is no more than an extension of the pharmacological action, which is the inhibition of prostaglandin production by the kidney. The mechanism of the loop of Henle and the renal papillae injury in acute overdoses is by blocking the blood flow in the renal medulla, which is dependent on prostaglandin E2, which is basically a vasodilator. The NSAIDs inhibit the cyclooxygenase, which prevents the formation of prostaglandin E2. And without this prostaglandin, the vasoconstriction causes ischemia. And the loop of Henle is particularly sensitive because of the high oxygen demand. The image here is from a horse, and it shows the location of the necrosis in the papillary area or the inner medulla. And that was a result of a chronic administration of phenylbutazone in that horse. Now, before we continue with some clinical cases, it is important to remember that intoxications can also take place when NSAIDs are not used properly. Some of those situations are, for example, when two NSAIDs are used together, or if they are combined with a corticosteroid, or for example when some drugs used for humans are used in dogs and cats. An example are naproxen and ibuprofen, which are contraindicated in small animals. So in all these situations, the risk of developing gastric ulcers goes up, and in fact the stomach is the first target organ, far ahead of the kidneys. Now, prior to seeing kidney damage, as I say, there will be GI signs, and also other conditions that predispose NSAIDs to cause renal failure are basically those that compromise blood flow to the kidneys, such as dehydration, hypertension, heart or kidney failure. As I said, the stomach is a lot more sensitive than the kidneys to the effect of NSAIDs. As we see here, they block the production of prostaglandin E2 that plays a critical role in the defense mechanisms of the stomach mucosa. Those mechanisms include the secretion of a mucus gel layer or a barrier rich in bicarbonate, which prevents the hydrochloric acid and the pepsin from entering in direct contact with the epithelial cells. Those prostaglandins are also necessary for proper blood flow to the mucosa. So without those prostaglandins, basically there is direct mucosal damage and epithelial injury by hydrochloric acid, which can result in ulcers. Now, if we look at the toxicity of NSAIDs in dogs, the Animal Poison Control Center reported more than 20,000 calls between 2005 and 2010 on exposures to NSAIDs, and ibuprofen was the most common drug relating those exposures. So the toxic signs kind of follow a dose-response relationship. The GI tract is the first organ affected, with signs of vomiting, diarrhea, nausea, abdominal pain, anorexia. With ibuprofen, that happens with an acute exposure of more than 100 milligrams per kilogram. If the dose is more than 175 milligrams per kilogram, we see kidney problems on top of the GI signs. And if the exposure is more than 400 milligrams per kilogram, we see CNS signs that include seizures, coma, and collapse, and obviously death. Now, here is a paper of 434 dogs with NSAIDs toxicosis that were treated with fluid therapy, lipid emulsions, or therapeutic plasma exchange. And the objectives were to compare the outcomes of dogs treated with just IV fluids, or with intralipid therapy, or with plasma exchange. So on this first table, we see the number of dogs exposed to either ibuprofen, carprofen, or naproxen. If we look at the ibuprofen, there were 25 out of the 434 exposures, and 212 animals, they all received a GI toxic dose. A renal toxic dose was diagnosed in 164 out of the 212 dogs, and a CNS toxic dose was attained in 70 of the 212 dogs. Now, the good news is that the total survival rate was 99% with proper therapy. And after 1 year of follow-up, up to 87% of those dogs were still alive and doing fine. So what are the general treatment recommendations for acute overdoses? Here we have a table with the treatment summary for each one of the NSAIDs. Traditionally, the treatment consists of aggressive decontamination that includes induction of emesis and activated charcoal, and then giving GI protectants like antihistamine, 2 antagonists, proton pump inhibitors like omeprazole, and prostaglandin analogs like misoprostol. Now, I should say that those GI protectants should be given for at least 7 to 10 days or even more with severe doses. And obviously IV fluids need to be given to protect those kidneys at least 2 to 3 times maintenance for at least 48 to 96 hours. And these are obviously very important with nephrotoxic dose ingestions. And ideally, you want to monitor renal functions along with the IV fluids. Now, there are a few dogs that were given also intralipid therapy or plasma exchange on top of the IV fluids. And they found that dogs given the intralipid therapy had less of an elevation of creatinine compared with those treated with only IV fluids. Similarly, the incidence of acute renal failure was lower in dogs treated with the plasma exchange. This technique basically involves the separation of the cell components of blood from plasma, which is replaced with that from a donor dog. And because NSAIDs are highly protein bound, you remove a lot of the drug in blood with this technique. And basically, plasma exchange is one of those things that they recommended and should be considered in the management of severe intoxications. And as I said, the toxicosis carries an excellent prognosis if we treat them promptly. Now, you may wonder, how about hemodialysis? Well, the truth is that it's not very effective because the NSAIDs are highly protein bound and they don't readily diffuse across traditional dialyzers very well, unless you were to put a charcoal cartridge in the hemodialysis circuit. Now, the next toxicant is cholecalciferol, which is found in rodenticides like Kintox or Rampage. The concentration in the bait formulas is about 0.075%, which is important to calculate how much the animal ingested if the owner can provide that type of information. As we can see on this slide, cholecalciferol is actually produced in the skin from cholesterol. It can also be present in the diet of some foods or dietary supplements. And in fact, it is used as a medication to treat diseases like rickets. The cholecalciferol itself is not very toxic until it gets converted to the active metabolite in the kidney. It goes through a first hydroxylation in the liver, producing 25-hydroxycholecalciferol, which is also known as calcifediol, which has a very long half-life of up to 19 days, excuse me. And then it goes to the kidney for a second hydroxylation, where the active 1,25-dihydroxyl vitamin D3, also known as calcitriol, is produced. And this last reaction is actually the rate limiting step. It happens slower than the other reactions. Now, cholecalciferol is actually an essential vitamin that is fat soluble, but as we see here, the quantities required are extremely low. One international unit of vitamin D3 is equal to 0.025 micrograms of cholecalciferol, and according to NRC requirements in puppies, they need about 22 international units per kilogram. So if we multiply the two, a puppy of about 1 kilogram only needs 0.5 micrograms per kilogram of body weight. And as we can see, the toxic dose is at least 1,000 times greater, starting at 0.5 milligrams per kilogram of body weight. Now, in order to understand the mechanism of action, it is necessary to see what drives calcium homeostasis. Calcium is regulated or controlled by a parathyroid hormone, the active form of vitamin D3, which is produced in the liver, and by calcitonin. With an overdose of cholecalciferol, the concentration of calcium in serum will markedly raise because the absorption of calcium and phosphorus increases in the intestines, and also because in the presence of parathyroid hormone there will be mobilization of calcium from the bone. It basically stimulates the osteoclastic proliferation and then the resorption of the bones. So what can we do to lower those calcium concentrations from serum? Well, basically the treatment will rely on fluid therapy with furosemide to enhance the elimination through the kidneys. We also have to use corticosteroids to decrease the intestinal absorption of calcium, and finally give drugs that mimic the action of calcitonin that have an antagonist effect on the bone resorption. So the clinical signs are basically associated with the hypercalcemia. They are primarily cardiovascular, gastrointestinal, and especially renal. Within 18 to 36 hours of the exposure, the animal starts showing anorexia, lethargy, nausea, weakness, vomiting that is usually hemorrhagic, also diarrhea that is hemorrhagic, polyuria, polydipsia, and electrocardiogram changes. We can make a diagnosis by detecting an elevation of phosphorus that usually precedes the hypercalcemia, but after 24 hours we will definitely see that calcium elevation and kidney problems that we can detect by elevation of BUN, creatinine, low specific gravity, proteinuria, glycosuria. Now, unfortunately, most of the animals, at least in the past, end up dying. Nowadays, we have biphosphonates that we will see in a minute are very effective. And as I say, it used to be a nightmare to treat these animals until these biphosphonates came along. The typical lesions will be those of a metastatic mineralization that we see here and basically everywhere in the body. Particularly in the basement membranes of the tubules and the glomeruli. This is actually an irreversible lesion, and we can see those arrows pointing to the glomeruli that are destroyed by calcification. These lesions will also be present in other places, as I say, vessels, gastric mucosa, myocardium, and now let's move on to the treatment. If the dog remains clinically normal and maintains normal calcium and phosphorus values for 72 to 96 hours after the ingestion, he would not be expected to develop clinical signs or changes associated with the toxicosis. The treatment should follow an order. If the exposure took place in less than 3 hours, you want to induce emesis. And follow that up with activated charcoal and a cathartic. If the animal is normal, we need to determine a baseline serum calcium concentrations as soon as the animal is presented, and a potential, particularly if he ingested a potential toxic dose. Now you may wonder if can we start treatment at this point that the animal is normal? Probably not, because if you treat, you will not see the elevation of calcium, and in fact you may cause a hypocalcemia, which in of itself can also be detrimental or even kill the animal. If the animal is clinically affected and the calcium is already elevated, we have to treat to return those serum calcium levels back to normal. for as long as necessary. In order to lower serum calcium, the therapy includes IV fluids at 2 to 3 maintenance together with Lasix. This allows for the calcium to go out with the urine. Corticosteroids will also prevent the absorption of calcium from the intestines. If phosphorus is high, we may include phosphate binders like aluminum hydroxide with the food. If we cannot lower that calcium with IV fluids and steroids, we will need to use calcitonin or biphosphonates to decrease the osteoclastic bone activity. Calcitonin is not as good as the biphosphonates because the animal tends to become refractory after a few doses. It is a lot more expensive than biphosphonates, and also we would need to administer more frequently than the biphosphonate. Now, the good thing about pamidronate, which is a biphosphonate, is that it will lower calcium levels, and you can basically pull out the IV fluids from the animal and treat him as an outpatient basis instead of being hospitalized with IV fluids for several weeks. Now, the prognosis is good for animals that are decontaminated early or that receive treatment to decrease those serum calcium concentrations. Obviously, before the soft tissue mineralization takes place. Here we have an experimental study to evaluate the use of pamidronate disodium to reduce cholecalciferol-induced toxicosis in dogs. They use 20 beagles randomly assigned to 4 groups of 5 dogs each, and all of them receive a dose of 8 milligrams per kilogram of cholecalciferol, which is enough to kill some of them, but is still lower than the LD50, which is 13 milligrams per kilogram. So you would not really expect this dose to kill most of the dogs, and most of them would obviously survive. They made 4 groups that were given the following treatment at 24 and 96 hours of the exposure. The first one received only 150 mils of saline solution, IV. The second one received a low dose of pamidronate with the IV fluids, and the third one a medium dose of 1.3 milligrams per kilogram with the IV fluids, and the highest dose group got 2 milligrams per kilogram of pamidronate. Now, if we look at the results, all the dogs in the IV fluids group got very, very sick, and one had to be euthanized on day 3. The others developed polyuria, polydipsia, anorexia, melena, hematemesis, dehydration, and weight loss. The dogs given the pamidronate did not show severe clinical signs, very mild signs, and if we look at the body weights at 7 and 14 days after the exposure, they did not really have as much loss of body weight as the ones as the group given only IV fluids. If we look at the serum calcium, the groups given pamidronate had significantly lower levels than the IV fluids. The arrows point to the days which pamidronate was given, which is 24 hours and 96 hours. And if we look at the creatinine in serum, the group given the highest dose of pamidronate did not really have any elevation compared with the other groups. Now, they also measure the glomerular filtration rate, which is definitely the best indicator of kidney function. And a typical dose-related effect was evident in all the treated groups. On the IV fluids, there was a decrease of approximately 55% of kidney function on day 3, and was a lot worse than the pamidronate groups. On the left figure, we can see that the calcium to phosphorus ratio raised in the IV groups during the initial 4 days. But those animals actually recovered by day 14. So this is important because if the animals do not receive a lethal dose, they will eventually recover. Now, they concluded that pamidronate at 1.3 and 2 milligrams per kilogram at 24 and then 96 hours of the exposure was effective was effective, reversing all the cholecalciferol induced hypercalcemia and hyperphosphatemia. The mechanism of action, as we just said, is by inhibiting bone resorption and decreasing calcium absorption from the GI tract. And this study is actually a very significant breakthrough in the treatment of cholecalciferol, because as we just said, the alternative was a nightmare. You would need to keep the animal hospitalized for several weeks with IV fluids and corticosteroids, and do continuous calcium measurements to adjust the treatment. With palmitoronate, you can afford to treat the animals on an outpatient basis. This is the final slide, and basically there are other causes of hypercalcemia that need to be ruled out when there is an uncertain history of cholecalciferol exposure. And the best way to diagnose cholecalciferol is by measuring calcifediol in serum, or the liver if the animal is dead. Remember that this is the metabolite that is produced in the liver and has a very long half-life of 19 days. And if we were to measure parathyroid hormone, we would see a decrease because of the negative feedback of calcitriol on the active form of vitamin D3. Now, the long half-life of vitamin D3 in the liver explains why we need to monitor calcium for several weeks. And ideally, when we pull out the treatment, it should be rechecked for several days to make sure that there is no more vitamin D in that liver that is going to raise up the calcium levels again. So this is the final slide, guys. On the next one, we will continue talking about more toxicants that affect the kidneys. So until next time, take care, and bye-bye for now.